All right, so this lecture is case-based practice, genetic dermatopathology correlation. So the goal of this lecture is to give you some examples of still-based images of dermatopathology and the concept of linking the diagnosis to genetic disease and understanding the relationship between pathology as well as mechanism of disease. So we'll start with the first case. Take a look at this lesion. It's a shave biopsy. You can pause your video and put together your differential diagnosis of what you're looking at. And after thinking about it, you may notice that there is a verrucous-looking architecture to the lesion at low power. The stratum corneum appears to have areas of eosinophilic V-shaped stratum corneum with some parakeratosis. On higher power, the main cell that you need to observe are these foamy histiocytes. So what's your diagnosis? So you should have your diagnosis in mind. And then you look at this question. Development of these lesions are associated with which mutation? So first you have to know the diagnosis. Second, you have to know the diagnosis is associated with what type of syndrome. And then you have to know the mutation that is usually associated with that syndrome. Unfortunately, board questions are often multiple order questions, and so it requires you to understand at least 2 or 3 different associations to be able to get the question correct. So going back, if you were thinking that this was a verruciform xanthoma, you were correct. Now, how can you remember what a verruciform xanthoma looks like? So you're going to need to remember the verrucous architecture. You're going to need to remember the V-shaped stratum corneum with parakeratosis, and you're going to definitely need to remember the foamy histiocytes in the dermis. Verruciform xanthomas. Verruciform xanthomas are often associated with a syndrome called child, and child is caused by a mutation in which of the following genes? The answer is C. NSDHL. That is the association with child syndrome. It's good to practice recognizing the associations of the other genes with the diseases. So ATP7A is associated with Menkes disease. LEMD3 is associated with Buschke-Ollendorff disease. REC-QL2 is associated with Werner syndrome. And neurofibromatosis 1 is associated with neurofibromatosis. Now let's delve in a little bit about verruciform xanthomas and child disease. So verruciform xanthomas is a xanthoma variant that commonly presents as a single verrucous, papillomatous, or keratotic plaque or nodule on the oral or anogenital mucosa. Other less common associations are the perioral area and the esophagus and other parts of the aerodigestive tract. The lesion is found most frequently in individuals between 40 and 60 years of age. However, of course, there are exceptions. Men and women appear to be affected equally. And verruciform xanthoma is typically a painless, slow-growing lesion, and as you can see here, present on the tongue. Oral verruciform xanthoma has been seen in association with oral submucous fibrosis, as well as lichen planus, leukoplakia, oral squamous cell carcinoma, oral chronic GVHD, oral discoid lupus erythematosus, and oral pemphigus vulgaris. Extraoral verruciform xanthoma has been recognized in lichen sclerosis, autosomal recessive dystrophic epidermolysis bullosa, child syndrome, lower extremity lymphedema, lymphangioma circumscriptum, and KID syndrome. KID syndrome stands for keratosis, ichthyosis, and deafness syndrome. So you can see that verruciform xanthoma is associated with a variety of different diseases. However, when you have a multiple choice question, you should be able to use process of elimination to figure out which is the most likely association. And in that case, child syndrome was the answer, and NSDHL was the best gene defect associated with child syndrome. So let's get in a little bit more to that gene defect. In child syndrome, the cutaneous manifestations are termed child nevi. Verruciform xanthomas have been reported to occur within child nevi, especially those occurring within the folds. Oral verruciform xanthomas may also be seen. Child syndrome is caused by a mutation in the nicotinamide adenine dinucleotide phosphate steroid dehydrogenase-like, or NSDHL gene. This gene is needed for cholesterol synthesis and the basis behind the theory of NSDHL gene mutations leading to verruciform xanthoma lesions. So you can imagine that if we have a gene that is responsible for cholesterol synthesis and homeostasis, and it's defective, then you're going to get accumulation of a lot of cholesterol. And in fact, the histiocytes are the ones that are going to have to clean up the mess. And so they're going to come in, they're going to proliferate, and they're going to cause a reaction to the overlying epidermis that is very characteristic of a verruciform xanthoma. So this is a xanthoma at the heart of it, but it takes on a verruciform appearance. It's not completely understood exactly how the NSDHL gene mutation leads exactly to the architectural changes in a verruciform xanthoma. However, without research funding, it's probably not going to be delineated very clearly in the near future. The cause of verruciform xanthoma when not associated with child syndrome is unclear. It has been suggested that epithelial compromise, secondary to local trauma or inflammation, leads to a release of epithelial lipids that are taken up by macrophages. No evidence of human papillomavirus has been found in verruciform xanthoma. So again, this is not your classic verruciform lesion. This is not your classic verruca vulgaris. This is a xanthoma that takes on a verruciform architecture. Now, this picture is very striking, and when you see it once, you should be able to remember it forever. This is a child with child syndrome. So what does CHILD stand for? CHILD is an acronym standing for congenital hemidysplasia with ichthyosiform erythroderma and limb defects. It's an inherited disorder affecting primarily women that is characterized by ichthyosis-like skin abnormalities and limb defects on one side of the body. If defects of the other side and other body organs are present, they are usually on the same side of the body as the skin and the limb abnormalities. Child syndrome is a hereditary disorder transmitted by an X-linked dominant trait. The faulty gene is on the long arm of the X chromosome, XQ28. The protein enzyme product coded by the gene has been identified as NSDHL, which I expanded down below, and governs an essential step in the biosynthesis of cholesterol. We all love biochemistry pathways, and so we're putting here the NSDHL, or 3-beta-hydroxysteroid dehydrogenase pathway. You definitely don't need to know this in detail, but you should understand where the NSDHL enzyme is situated in the entire process of conversion of lanosterol to cholesterol. So it sits somewhere within the 5th step of the enzymatic reaction. And it just goes to show you that when any one of these steps is compromised, you're probably going to lead to some type of pathology. It's interesting that a defect in this enzyme leads to such marked hemidysplasia type phenotype, and it's unclear exactly why there is a bilateral, or not a bilateral, but a unilateral rather, phenotype. And so what makes one side of the body more susceptible than the other? It's not entirely clear. It's very interesting. So this is a schematic representation of the post-Squaline cholesterol biosynthesis. Here for reference, I listed the individual enzymes, so you can look at each number, 1, 2, 3, and correlate the name of the enzyme with that for your reference. However, you do not need to know this for boards, but you should appreciate the complexity of the role of this enzyme defect in producing a very striking dermatologic phenotype. A little bit more about child syndrome, a few factoids. So child syndrome is usually present at birth. It may become first apparent at some point during the first month of life. The skin is usually dry, itchy, red, and scaly, as we call ichthyosiform erythroderma, on one side of the body, although minor skin involvement in the shape of lines or segments may occur on the opposite side of the body. Bands of normal skin may be found in the affected side as well. and patients with child syndrome may be bald on one side of the head and have claw-like nails. Limb defects usually occur on the same side of the body as the major skin symptoms. These defects may range from underdevelopment of fingers and toes to complete absence of a limb. Some of the types of skeletal defects that may occur include abnormal ribs, anomalies of the shoulder blades or scapula, webbing of the skin between the joints, and absence of muscles of the breast. Heart defects sometimes associated with this syndrome include defects in the walls between auricles and or ventricles, as well as complex heart disease in which less than adequate amounts of oxygen get to the organ, leading to cyanosis. Abnormalities of the central nervous system, blood vessels, kidneys, thyroid, lungs, and adrenal glands, and of the reproductive and urinary system may also occur. Most of these abnormalities result from underdevelopment of the affected side of the body. So what is the high yield takeaway? The NSDHL mutation is associated with child syndrome and verruciform xanthomas. They may ask you to recognize nicotinamide adenine dinucleotide phosphate steroid dehydrogenase-like, or NSDHL, as the mutation among several different genes in a multiple choice question. Case 2. You can pause your video. However, many of you probably got this diagnosis within a few seconds. This is an instant recognition diagnosis. So you should be able to take one look at this and come up with the diagnosis. However, if you are debating exactly what you're looking at, let me bring to your attention that these appear to be calcified fibers distributed among the dermis. Some of you may have been thinking, are these histiocytes or are they some type of other deposit? However, this is a very classic look of a disease entity. So think about what you think it is. Here's a higher power view just to show you some calcified fibers. Now remember, on H&E, calcified fibers become very purple. So if you know the diagnosis, then the next step is going to be to know the genetic mutation that's associated with the diagnosis. Take a look at the answer choices and choose the correct answer. So the correct answer is C, ABCC6 gene, which is associated with pseudoxanthoma elasticum. You probably already know if you were a second year, but if you're a first year, you might not be there yet, but ATP2A2 is associated with the keratosis follicularis disease or Darier's disease. ATP2C1 is associated with benign familial pemphigus or Haley-Haley disease. GNAC is associated with Sturge-Weber syndrome. And P10 is associated with Cowden's disease, at least. It's also associated with Banyan-Riley-Ruvalcaba. Here's a classic Kodachrome that you should recognize. So you see these kind of xanthomatous papules and plaques on the neck. This is a classic appearance and a classic Kodachrome of pseudoxanthoma elasticum. If you were to biopsy these papules, you would get the pathology seen here. It's interesting because it doesn't really take on a xanthoma on pathology. That's why you get the name pseudoxanthoma elasticum. So think about elastic fibers being calcified. So this is your pseudoxanthoma. It's not a true xanthoma. So let's talk a little bit about the pathophysiology of pseudoxanthoma elasticum. The defective gene is the ABCC6 gene, as I mentioned. You can see here that the ABCC6 gene product is a membrane-associated protein. It's mainly found in the liver and the kidneys. To a lesser extent, it's found in the eyes, the blood vessels, the stomach, and the skin. This protein transports molecules across the cell membrane. It appears to simulate release from the cell of ATP, which is immediately hydrolyzed. The pyrophosphate product helps regulate calcification and other mineralization processes within the body. So that's your normal state. However, when the ABCC6 gene product is mutated, what happens is you get increased calcification. So the mutation of ABCC6 in this disease contributes to multiple diseases, including generalized arterial calcification of infancy. In pseudoxanthoma elasticum, breaks occur in the Bruch membrane of the eye. Frequency of optic disc drusen is increased markedly. Systemic features include skin laxity due to defective elastin, excessive calcification in elastic media cause vascular disease, and there may be hemorrhage resulting or occlusion. Heart problems occur, including coronary artery disease and malfunction of heart valves. So you can see pseudoxanthoma elasticum on the top right panel presenting as neck skin hyperelasticity and dimpling in pseudoxanthoma elasticum. You can see the plucked chicken skin appearance of pseudoxanthoma elasticum. And here's a picture of the drusen within the retina in pseudoxanthoma elasticum. And you can see the fundus here with the cholesterol and calcification defects within the retina. So the high yield take-home point is that ABCC6 mutation is associated with pseudoxanthoma elasticum, and this is a multi-organ disease. These patients should be followed up by multiple specialists, including ophthalmology. Given the risk of arterial calcification, these patients should also be seen by cardiology. You will be expected to know this on your dermatology board exams. Case 3. Take a look at this picture. And what stands out to you, think about the patterns that you were seeing. And this is a still image that should be diagnostic for a particular type of lesion that you're going to see a lot in dermatopathology. How would you describe the cells on the left? How would you describe the cells in the middle? And how would you describe the cells on the far right? So the cells on the left seem to be more hematoxylinophilic, and they seem to be more of a precursor cell. The cells in the middle appear to almost be giant cells in a way. However, it's unclear whether or not they're foreign body giant cells or some other type of giant cell. The cells on the right look to be shadow cells, meaning that they are just the outlines of previous cells that had been there before. The nuclei is completely gone. So just here on the right side of the picture, you should be able to get the diagnosis. This pathology is most associated with an activating mutation in which gene? CTNNB1 or beta-catenin is associated with pilomatricomas and Gardner syndrome. Just as a review, P10 is associated with sclerotic fibromas and Cowden's. CYLD mutation is associated with spiradenomas and cylindromas, as well as trichoepitheliomas and Brooks-Spiegler. The BHD gene is associated with fibrofolliculomas and trichodiscomas in Burt-Hogg-Debye. And the BRAF mutation is associated with nevi, melanoma, and even Langerhans cell histiocytosis. Again, these are random genes listed here, and you need to self-review as we don't have time to go through everything in this one lecture. However, I'm including them here for reference. What we're going to do for this case is associate or at least focus on the CTNNB1 or beta-catenin link with pilomatricomas and Gardner syndrome. So to understand this, you should understand exactly the role of beta-catenin in the development of human hair follicle morphogenesis. So this blue outlines dermal papilla, and you can see the red is often associated with the very base of a developing hair follicle, TGF beta 1, as well as nuclear FHL2, is often associated with the outer portion of the hair follicle, and this is an anagen hair follicle. So the schematic shows the separation of where nuclear beta-catenin expression and TGF-1 beta nuclear FHL2 co-expression are existing in a spatial orientation in the normal anagen hair follicle. When you get to a pilomatricoma, what you're going to see is mostly in stage 1 nuclear beta-catenin activation. As you move on to stage 2, you're going to have a shift of nuclear beta-catenin as well as a little bit of TGF-beta1. You'll start to pick up some nuclear FHL2 activity. And then in stage 4, which is the stage that we mostly see, we're going to see nuclear beta-catenin activity in a lot of the precursor cells. And you're going to see areas of ghost keratinization, which is the lack of nuclei. So these are the ghost cells or the shadow cells. They're usually referred to by both of those names. However, not to be confused with ghost cells in pancreatic paniculitis. Shadow cells are often the terminology used in a pilomatricoma. It's important to remember that pilomatricomas are seen in multiple types of diseases. These include myotonic dystrophy, Gardner syndrome, Rubinson-Taybi, and Turner syndrome, to name a few. If a patient has more than 6, I would say 6 or more, based on the literature, pilomatricomas, you should start working this patient up for some type of genetic defect. So the high yield takeaway point is that activating beta-catenin mutations are associated with pilomatricomas. Case number 4. Here you can see a very ichthyotic looking skin. From low power, it's relatively unremarkable. It doesn't look very inflammatory. As you go on higher power, what you may notice is an absent or diminished granular layer. However, usually when you see hypogranulosis, you're looking for overlying parakeratosis. But in this case, you have hypogranulosis or a diminished granular layer, but orthokeratosis on top. So it's a little bit of a paradox here. So putting the clinical together with the histopathology, what is your diagnosis? This patient likely has a defect in which of the following genes? The answer is filaggrin. Filaggrin defects are often associated with ichthyosis vulgaris. As we mentioned in previous lectures, steroid sulfatase is defective in X-linked ichthyosis. ABCA12 is associated with harlequin ichthyosis. And keratins 1 and 10 are associated with epidermolytic hyperkeratosis. This is a schematic showing you the role of filaggrin in the granular layer and the stratum corneum. Loss of filaggrin expression on the right side of the picture leads to skin barrier disruption and penetration of allergens. So what happens is when you have a defect in the normal construction of filaggrin, you have a breakdown of keratohyalin granules, and what ends up happening is this allows the skin barrier to become a lot more susceptible to external allergens. It becomes a lot more susceptible to become dehydrated, dry, itchy. Immune cells are going to come in. They're going to start reacting with the antigens, the new antigens from the outside world. Langerhans cells are going to present antigens to the immune system. The immune system is going to come in to the skin and try to react. And you're going to get an inflammatory condition, which is very similar to atopic dermatitis. Remember that atopic dermatitis also has filaggrin mutations. At least some patients have been shown to have filaggrin mutations. Other forms of atopic dermatitis are usually due to either defects in the immune system, which are not completely understood, or defects in other structural skin proteins, as well as the ability to interact with the exterior microbiome. So we don't have time to get into all those today, but I will leave this cartoon here for reference for you to be able to study the structure of the skin as well as the location of keratohyalin granules and filaggrin in the granular layer. I do want to mention that in the stratum corneum, filaggrin proteolysis releases histidine, which is then deaminated to form trans-urocanic acid. That trans-urocanic acid is converted to cis-urocanic acid by UV irradiation. The glutamic acid released from filaggrin is converted to pyroglutamic acid, which may function as a natural moisturizing substance. So not only does filaggrin disturb the architecture of the skin, it also limits the natural moisturizing substance which we can naturally produce when we have normal levels of filaggrin. So this means that not only is the architecture of the skin disturbed, but the ability to keep the skin moisturized is disturbed with filaggrin mutations. As you go back to that clinical picture, you can understand that this looks like very dehydrated skin. In fact, it looks like a bed of dirt that has dried out in the sun. And you have these very cracked polygon shapes within the ground. And we've all seen this. And the skin is very similar. So when we have a defect in filaggrin, not only do we have an architectural breakdown here, but we also have the ability to not be able to moisturize the skin normally. Now, in the granular layer, filaggrin is formed from profilaggrin, which is a highly phosphorylated, histidine-rich, very basic protein. Normally, filaggrin aggregates keratin filaments and flattens the shape of keratinocytes. Other events include release of lipids and cell envelope proteins from Golgi-derived organelles, known as lamellar granules, that form the skin barrier. So, fortunately and unfortunately, we have worked out the ability to link structural proteins in many different layers of the skin to some type of phenotypic expression. There's many types of ichthyosis that are the result of direct structural protein breakdown. So the high yield take-home point for this case is that filaggrin mutations are associated with absent or diminished granular layer on pathology. Again, it's counterintuitive that you're going to have a diminished granular layer and orthokeratosis. This is very unique to ichthyosis vulgaris. You can also think about atopic dermatitis. Now, chronic spongiotic dermatitis or chronic atopic dermatitis will often show hyperorthokeratosis and hypergranulosis. So that means that the patients that are able to form that lichen simplex chronicus definitely do still have filaggrin and enough filaggrin to make some type of hypergranulosis. Remember, their skin is very thick. So they're able to thicken the skin in response to chronic mechanical stimulation. In response to chronic atopic dermatitis state, they're able to upregulate their normal filaggrin. So we've reached the end of the cases, but I did want to list several of the entities that were mentioned within the multiple choice questions. So with any good question in dermatology and dermatopathology, each multiple choice set is going to give you 4 different entities to review. So again, I advise you to look up the link between all of these different genes and the associated disease on your own for self-study. There's plenty of great resources out there, including all the dermatology textbooks, dermatopathology textbooks, and I recommend all of the other online dermatopathology teaching resources out there, which we've referred to in other videos. So please have fun delving into the genetic dermatopathology and clinical pathology links. Happy studying.